Welcome to the deep dive. Today we're really getting into something foundational for nursing students, how different drugs affect the female reproductive system.
Exactly. We're going to unpack the key medications, thinking about how they work and what nurses really need to know for patient care.
We'll break it down into three main chunks. First up, sex hormones, estrogens, progestins, and also those estrogen receptor modulators.
Then we'll look at fertility drugs.
Right. And finally, we'll tackle the drugs that influence uterine motility, oxytocics, abortifacients, and tocolytics.
The goal here is really to give you a solid, practical understanding that you can apply across different stages of a patient's life.
Okay, let's jump in. Starting with those sex hormones and the modulators, how do they interact with the system?
Well, the key is understanding that the female reproductive system runs on this, cyclical hormonal rhythm.
Right.
And these drugs essentially tap into that. They might mimic the natural hormones, or sometimes they block their actions.
So they work with or against that natural cycle. Makes sense. And the two big players are estrogens and progestins.
That's right. For estrogens, you'll see names like estradiol, conjugated estrogens, esterified estrogen, estropipate. Lots of options.
And they come in different forms too, don't they? Like pills, patches?
Yeah, exactly. Oral transdermal patches, intravaginal routes, even injections. And that variety affects how they're absorbed and used by the body, which is, important for nursing.
Okay. And progestins, what are some examples there?
Common ones include Levonorgestrel, Levonorgestrel, Hydroxyprogesterone, norethindrone, progesterone, and Mifepristone.
Mifepristone, that's the emergency contraceptive one.
Correct. And very often you'll see estrogens and progestins used together. Combination meds are really common, especially for birth control and HRT.
Let's focus on estrogens first then. What are their main jobs, therapeutically speaking?
A big one is hormone replacement therapy, HRT. When the ovaries aren't working right, or maybe they've been removed.
For menopause symptoms too, right?
Definitely. Big relief for many women. Also used for things like female hypogonadism, ovarian failure, even sometimes to prevent postpartum breast engorgement.
And they're in combination contraceptives, as you mentioned. What about bone health?
Crucial point. Estrogens help slow bone loss and osteoporosis. That's incredibly important for nurses working with postmenopausal patients.
So understanding that link between falling estrogen and fracture risk is key for patient education and assessment.
Absolutely. And they can even be used palliatively in certain hormone-sensitive cancers. Quite a broad scope.
Wow, yeah. So fundamentally, they're involved in developing the whole female reproductive system and secondary sex characteristics.
That's the basis. Hormonally, they affect FSH and LH release from the pituitary. Those are the main signals controlling the ovaries.
Okay.
Physically, they cause some blood vessel dilation, fluid retention, protein building.
Yeah.
They change cervical mucus, help conserve calcium and phosphorus for bones.
So they really influence bone formation directly, too.
Yes. And they inhibit ovulation, prevent that postpartum breast discomfort, and make the uterine lining proliferate or thicken.
Interesting. And you mentioned cancers. They can even compete with androgens, male hormones.
Right. They can be for receptor sites, which is why they sometimes have a role in treating certain prostate cancers in men. Systemically, you see effects like potential protection against atherosclerosis, keeping calcium in the bones, maintaining those secondary sex characteristics.
Okay, quite far-reaching. Now let's switch over to progestins. What are their main therapeutic uses?
Contraception is a huge one, especially combined with estrogens for maximum effect, but also treating amenorrhea, that's absent periods, and functional uterine bleeding.
They're part of fertility programs, too.
And some, like Mifepristone, are used for that postcoital emergency contraception. And similar to estrogens, they can be used for specific hormone-sensitive cancers.
So what's their mechanism? How do they work in the body?
Their key role is transforming that proliferative endometrium, the thickening uterine lining, into a secretory one. That's essential if a fertilized egg is going to implant.
Ah, okay. Preparing for pregnancy.
Exactly. They also put the brakes on FSH and LH secretion, which stops follicles from maturing and prevents ovulation. Plus, they inhibit uterine contractions and can have some, anabolic and estrogen-like effects too.
And in contraceptives, how does that work exactly? Is it just stopping ovulation?
That's a major part of it, yeah. By adding progestins, often with estrogens, you basically fool the brain's control centers, the hypothalamus and pituitary.
You trick them.
Sort of. It stops them releasing GnRH, FSH, and LH, no FSH and LH surge, no ovulation. And even if an egg did somehow get fertilized, the progestin makes the uterine lining unreceptive to implantation.
Got it. A multi-pronged approach. Okay, so how does the body process these? Pharmacokinetics. Estrogens first.
Well, oral estrogens are usually absorbed pretty well, but they get metabolized quite a bit by the liver on that first pass.
The first pass effect, right.
Exactly. Then they're mainly excreted in the urine. And critically for nursing, both estrogens and progestins cross the placenta and get into breast milk.
Good to know. And those different forms, pills, patches, rings, affect absorption, right?
Definitely. Each route has its own pattern.
And progestins, similar story.
Pretty similar, yeah.
Yeah.
Generally well absorbed, also extensively metabolized by the liver, excreted in urine, and again, they cross the placenta and enter breast milk. You see them as pills, injections, patches, creams, gels, even those intrauterine devices, the IUDs.
Okay. Now, this is super important for practice.
Yeah.
Contraindications and cautions. When should we absolutely not use estrogens?
Right. Big ones. Undiagnosed abnormal vaginal bleeding, you need to know the cause first. Any history of breast cancer or other estrogen-dependent cancer.
Thromboembolic disorders, too. Clots.
Absolutely. History of DVT, stroke, PE, definite contraindication. And heavy smokers are at much higher risk for clots with estrogens.
Makes sense. What else?
Liver albums are a major issue because the liver metabolizes them. And pregnancy is an absolute no-go risk of serious fetal defects. Breastfeeding is usually avoided too, as it can decrease milk supply and quality.
Okay. And specific cautions.
Need to be careful with metabolic bone disease, kidney issues, liver impairment conditions that affect how the drug is handled.
And for progestins. Similar contraindications.
Largely overlapping, yes. Similar concerns about undiagnosed bleeding, hormone-sensitive cancers, thromboembolic history, liver dysfunction, pregnancy.
Anything specific to progestins?
Maybe use caution with endometriosis or after pelvic surgery because of effects on uterine blood vessels. And then there's drospirenone.
Ah, yes, the one with the potassium risk.
Right. It has this anti-mineralocorticoid activity, so it can raise potassium levels. It's contraindicated if there's a risk of hyperkalemia, so kidney disease, liver disease, adrenal problems, or taking other potassium-sparing drugs.
Good flag. Any other cautions for progestins generally?
Yeah, conditions like epilepsy, migraines, asthma, or heart or kidney dysfunction might need closer monitoring, as progestins could potentially worsen them.
Okay, let's talk side effects. What are common issues with estrogens?
Genitourinary things are pretty common. Breakthrough bleeding, irregular periods, painful periods, sometimes no periods, changes in libido.
Systemic effects.
Fluid retention, electrolyte imbalances can happen. Headaches, dizziness, mood changes, weight changes, edema or swelling. GI stuff too, nausea, vomiting, cramps, bloating, even colitis sometimes.
Are there more serious, less common effects?
Yes, potentially serious ones include acute pancreatitis, cholestatic jaundice, that's a liver bile flow issue, and hepatic adenoma, which is a type of liver tumor. Rare, but important to know.
And adverse effects for progestins?
They can vary a bit depending on how it's given. Systemic effects often mimic estrogens.
So similar fluid retention, mood changes, etc.
Potentially, yes.
Yeah.
With a patch, you might get skin irritation at the site, plus systemic effects. Vaginal gels might cause headache, nervousness, constipation, breast enlargement, perineal pain.
What about IUDs?
They can cause abdominal pain, sometimes worsen endometriosis. There's a risk of abortion, pelvic inflammatory disease, or the device being expelled. Vaginal use generally can cause local irritation.
And drospirenone, again, that potassium issue is an adverse effect risk too, right?
Exactly. Increased potassium levels due to that specific activity.
Okay, drug interactions. This is always tricky. What should nurses know about estrogens interacting with other meds?
A key thing is the liver enzyme system, specifically CYP3A4. It processes a lot of drugs, including estrogens.
So drugs that affect that enzyme can change estrogen levels.
Precisely. Drugs that induce or speed up CYP3A4, like certain antibiotics, rifampin, some seizure meds like phenytoin, barbiturates, they can actually lower estrogen levels, potentially making them less effective.
What about other interactions?
Estrogens might boost the effects, both good and bad, of corticosteroids. They can potentially reduce the effectiveness of anticoagulants like warfarin, some thyroid meds, and oral diabetes drugs. Dosages might need adjusting.
And smoking.
Huge one. Smoking plus estrogen massively increases the risk of blood clots. Patient education is critical there.
Any food or supplement interactions?
Grapefruit juice can interfere with the breakdown of some estrogens, potentially raising levels. St. John's wort is another one that can affect metabolism and decrease contraceptive effectiveness. Definitely ask about herbal remedies, too, as they might interact.
Good point. What about interactions with progestins?
Some overlap. Those same CYP3A4 inducers, barbiturates, carbamazepine, phenytoin, plus others like riboflavin, certain penicillins, tetracyclines, rifampin can reduce progestin effectiveness.
So if someone's on progestin-only birth control and needs one of those drugs?
They absolutely need to use a backup contraception method. And St. John's wort, again, same issue, can decrease effectiveness.
Okay, that covers the hormones. Now, what about these estrogen receptor modulators, SERMs, like Raloxifene?
Right. Raloxifene is interesting. It's used to treat and prevent osteoporosis after menopause and also to reduce the risk of invasive breast cancer in that group. But it's not for treating existing breast cancer.
So it's not a hormone itself, but it acts on the estrogen receptors.
Exactly. It's selective. It binds to estrogen receptors, but has different effects depending on the tissue. Think of it as activating the receptor in some places like bone, but blocking it in others, like the uterus and breast.
So it gives you the bone benefits of estrogen without stimulating the breast or uterus as much.
That's the idea behind it, yes.
Yeah.
It's an agonist in bone, helps bone density, but an antagonist in uterine and breast tissue.
How is it handled by the body, pharmacokinetics?
It's taken orally, gets absorbed well, metabolized by the liver, but mainly excreted in the feces, interestingly. And like the hormones, it can cross the placenta and get into breast milk.
Contraindications. When should it be avoided?
Known allergy, of course. Definitely avoid in pregnancy and breastfeeding due to potential risks.
Cautions.
Big caution. In anyone with a history of venous thromboembolism, DVT, PNA. And also smokers, as that combination raises clot risk further. And it's not meant for premenopausal women.
Adverse effects. What should we watch for?
GI upset, like nausea and vomiting, can happen. Changes in fluid balance might lead to headache, dizziness, visual or mental changes. Hot flashes are common. Also skin rash, edema, sometimes vaginal bleeding.
What about serious risks? You mentioned clots.
Yes, there's a definite risk of VTE and pulmonary emboli, and clinical trials showed an increased risk of stroke death in postmenopausal women who already had heart disease or risk factors.
Okay, that's important to counsel patients about. So let's quickly recap the prototypes for this section. Estradiol, norethindrone acetate, and raloxifene. Key nursing points for estradiol.
Estradiol, most potent natural estrogen, used for menopause symptoms, osteoporosis prevention, hypogonadism, various routes, liver metabolism, urine excretion. Watch for side effects like corneal changes, photosensitivity, fluid retention, skin changes, GI upset, irregular bleeding, and those long-term cardiovascular and breast cancer risks.
Got it. Norethindrone acetate.
Synthetic progestin. Treats amenorrhea, abnormal bleeding, endometriosis symptoms. Component of contraceptives. Works like progesterone changes uterine lining, inhibits FSH-LH, prevents contractions, given orally. Liver metabolism, fecal urine excretion, monitor for clots, visual changes, migraine, skin issues, menstrual changes, fluid retention, weight gain.
And finally, raloxifene.
The SERM. Prevents treats postmenopausal osteoporosis, reduces breast cancer risk, not treatment, increases bone density, less uterine stimulation, oral route, long half-life, about 28 hours, liver metabolism, fecal excretion, key adverse effects, clot risk, VTE, PE, stroke, hot flashes, rash, nausea, vaginal bleeding, potential liver function changes.
Excellent summary. That gives us a really solid foundation on sex hormones and modulators. Shall we move on to fertility drugs?
Let's do it. Fertility drugs are essentially used to help stimulate the reproductive system in individuals who have working ovaries but are struggling to conceive.
Okay, and there are quite a few different ones, right?
Yes. Examples include cetrorelix, chorionic gonadotropin, HCG, clomiphene, various phallotropins, gynerelix, menotropins, urophallotropin.
What's the main goal with these?
Primarily to stimulate ovarian follicles to develop and then trigger ovulation. They might act directly on the ovaries, or they might signal the brain, the hypothalamus and pituitary, to ramp up FSH and LH production.
And they're often used in a specific sequence.
Very often, yes. Frequently involves using HCG after the initial stimulation to help the follicle mature and maintain hormone production. They're also essential for things like IVF, where the goal is to get multiple follicles developing so more eggs can be retrieved.
Interesting that some phallotropins are also used for men.
Right. Phallotropin alpha and beta can be used to help stimulate sperm production in men with a specific type of hormonal deficiency, hypogonadotropic hypogonadism.
Can you briefly explain what some of these different drugs do, like cetrorelix?
Sure. Cetrorelix works by stopping a premature LH surge, which could mess up the timing for egg retrieval or ovulation. Chorionic gonadotropin acts like LH to trigger ovulation.
And the phallotropins?
Those are basically FSH preparations. They directly stimulate follicle growth. Menotropins contain both FSH and LH activity. Urethropoietin is purified FSH, often used to induce ovulation or get multiple follicles going.
How are they usually given? And how does the body handle them?
Most are given by injection, subcutaneous or intramuscular. They're generally well absorbed and handled, much like the body's own hormones, metabolized by the liver, excreted by the kidneys.
Any exceptions to the injection route?
Clomiphene citrate is the main one. It comes as an oral tablet.
Okay. When are these drugs not appropriate? Contraindications.
Shouldn't be used if there's primary ovarian failure. The ovaries need to be able to respond. Also contraindicated if there are ovarian cysts during pregnancy or with idiopathic uterine bleeding. And of course, allergy to the specific drug.
Cautions.
Use cautiously during breastfeeding. Be careful if there's a history of thromboembolic disease, as some can increase clot risk, and caution with respiratory diseases too, due to potential fluid shifts.
What are the major risks or side effects we need to be aware of?
The big ones are a significantly increased risk of multiple births, twins, triplets, etc., and the potential health issues that come with that. There's also a risk of congenital anomalies.
And ovarian hyperstimulation syndrome, OHSS.
Yes, that's a serious potential complication. It ranges from mild abdominal pain and bloating to severe cases with lots of fluid buildup in the abdomen and chest and electrolyte problems.
Other side effects?
Headache, fluid retention, nausea, bloating, uterine bleeding, ovarian enlargement, rarely gynecomastia in male partners, and sometimes febrile reactions.
Let's use Clomiphene as our prototype here. What are its key features?
Clomiphene's main use is for ovulatory failure in women who still produce estrogen. It works by blocking estrogen receptors in the hypothalamus.
Tricking the brain again.
Kind of, yeah. The brain thinks estrogen is low, so it pumps out more GnRH, which tells the pituitary to release more FSH and LH, stimulating the ovaries.
And it's the oral one.
Right. Taken as a pill, usually for 5 days. It has a fairly long half-life, about 5-7 days. Metabolized in the liver, excreted in urine. Common side effects are hot flashes, visual disturbances, abdominal discomfort, nausea, vomiting, ovarian enlargement, breast tenderness, that risk of OHSS, and the increased chance of multiples.
Okay, that covers fertility drugs well. Let's move to our final section, uterine motility drugs.
All right. These are drugs that specifically target uterine muscle contractions. 3 main types: oxytocics to stimulate labor or manage bleeding, abortifacients to induce abortion, and tocolytics to slow or stop contractions.
Starting with oxytocics and abortifacients, examples.
Carboprost, dinoprostone, methylorganovine, Mifepristone, and the very well-known Oxytocin. Also, misoprostol has abortifacient effects, though it has other uses too.
How do the oxytocics work?
They directly stimulate receptors in the uterus to cause contractions. They work best when the uterus is already pregnant. Oxytocin also triggers milk ejection by acting on mammary glands.
And their main uses.
Inducing or augmenting labor is common. Critically, they're used to prevent and treat uterine atony after delivery, that failure of the uterus to contract down, which causes postpartum hemorrhage.
And abortifacients.
They stimulate uterine activity to expel the pregnancy. Some, like Mifepristone, block progesterone, which is needed to maintain the pregnancy. They're approved for termination within specific timeframes.
How are these given and processed?
Absorption is usually rapid, whether injected, oral, or vaginal. Metabolized in the liver, excreted in urine and feces. Important. They can cross the placenta and enter breast milk.
Administration details can vary, right?
Yes. Methylorganovine might start as an injection, then go to oral pills postpartum. Oxytocin is often IV for labor, IM for hemorrhage, or even nasal spray for milk letdown. Mifepristone is oral. Carboprost is IM. Dinoprostone is often a vaginal insert or suppository.
When should these be avoided? Contraindications.
Allergy, obviously. Also, situations like cephalopelvic disproportion, baby too big for pelvis, unfavorable fetal position, or complete uterine atony.
What about caution?
Be careful with coronary artery disease or hypertension, as they can cause vasoconstriction. History of C-section increases rupture risk with strong contractions. And caution with liver or kidney impairment. Oxytocin can be used during lactation for milk letdown, but monitor the baby.
What are the main adverse effects?
Often related to too much uterine stimulation. Hypertonicity, spasm, even rupture. This can lead to postpartum hemorrhage or fetal distress. GI upset, headache, dizziness are common too.
Any drug-specific risks?
Methylorganovine carries a risk of ergotism, nasty symptoms like BP changes, weak pulse, breathing difficulty, chest pain, cold extremities, confusion, seizures.
Wow. And oxytocin.
High doses infused for a long time can rarely cause severe water intoxication due to its ADH-like effect. Can lead to coma, even death. Needs careful monitoring.
Let's focus on oxytocin as the prototype oxytocic. Key points.
Indications are broad. inducing, augmenting labor, managing abortion, controlling postpartum bleeding, treating lactation issues, stimulates uterine muscle and milk ejection. Given IVV, immediate onset, or IM, slower onset, very short half-life, metabolized quickly. Watch for arrhythmias, BP changes, fetal heart rate slowing, nausea, vomiting, uterine rupture risk, that water intoxication risk, potential allergic reactions.
Okay, that covers oxytocics and abortifacients. Now the last group, tocolytics. What's their job?
Tocolytics do the opposite. They aim to slow or stop uterine contractions, usually to try and prevent preterm labor and give the fetus more time to develop if it's safe.
Are there different types?
Some drugs like Mifepristone, a calcium channel blocker, and indomethacin, an NSAID, are used off-label for this. But it's crucial to know the FDA warns against using terbutaline off-label as a tocolytic due to serious heart risks for the mother.
So what is approved specifically as a tocolytic?
The main one currently approved is hydroxyprogesterone caparate, brand name Makena.
And what's its specific indication?
It's proved to reduce the risk of preterm birth only in women pregnant with a single baby who have a history of a previous spontaneous preterm birth with a single baby, not for multiples.
How does it work?
It's a synthetic progestin, so it acts like progesterone. The exact way it prevents preterm birth isn't fully understood, but it likely involves maintaining uterine quiescence. It shares effects and risks similar to other progestins we discussed.
How is it given and handled?
It's an injection, either IM or subcutaneous, given once a week. Metabolized by the liver, excreted in urine and feces, it has a pretty long half-life.
Contraindications for hydroxyprogesterone caparate.
Should not be used if there's a current or past history of clots, thromboembolism. Also contraindicated with known or suspected breast cancer or other hormone-sensitive cancers, undiagnosed abnormal vaginal bleeding, cholestatic jaundice of pregnancy, liver tumors or active liver disease, and uncontrolled hypertension.
And potential adverse effects.
Can include depression, fluid retention, which can worsen hypertension, glucose intolerance or gestational diabetes, and thromboembolic events. Injection site reactions are common, and allergic reactions are possible.
So summarizing hydroxyprogesterone caparate as the prototype tocolytic.
Right. Indicated for reducing preterm birth risk in singleton pregnancies with a history of prior singleton SPB. Synthetic progestin, mechanism not fully clear. Weekly IM or SQ injection, long half-life, metabolized by liver, excreted urine feces. Watch for site reactions, glucose intolerance, fluid retention, depression, clot risk. Contraindicated with history of clots, certain cancers, liver issues, uncontrolled HDN.
Yes, it's a complex area, but having a solid grasp of these drug classes is absolutely vital for nursing practice. You'll definitely encounter these medications.
Absolutely. It's not just about knowing the names, but understanding how they work, why they're used, the potential downsides, and what we as nurses need to monitor and teach our patients. That understanding is key to safe administration, effective monitoring, catching problems early, and providing that high-quality holistic care we strive for.
Couldn't agree more. Being well-informed empowers us to be better patient advocates and educators.
Definitely.
So to wrap up our deep dive today, here's something to think about as you continue your studies. Considering the delicate balance of the female reproductive system and how powerfully these drugs can act, what are the most crucial aspects of patient education and monitoring that nurses must prioritize to ensure the best possible outcomes and patient safety? Something essential to keep reflecting on. Thanks for joining us.